So this 19 years old female has a severe learning difficulties and has been traumatized upper incisor. She has been brought by her care provider for the advice on how to straighten the teeth. She's in the full-time residential care because her mother is in physically disabled. After giving clear and detailed description of the various treatment options as well as the consequence of leaving either the malocclusion or traumatized teeth uncorrected, the patient is judged not to have capacity, who is legally most appropriate because she is in a full residential care. So no one else can consent. The father no, the mother no, the carer because of mother disability and the father's work commitment, the orthodontist and other colleague plans for the patient. Because she mentioned that she is in a full-time residential care. So I think they can provide them the carrier because mother father communication, neither parents can be easily attend. So I think because they mentioned that she's in a full residential care here, right here. Right here. So might be the care provider can also another independent that has compiled. So I think the care provider from the team in that case they can provide the consent. I'm selecting D here. Clear of maximum midline diastema with the assistance of anterior spring attachment to the central incisor. Example of clear of maximum midline diastema with the assistance of anterior attached to the central incisor. Example of reciprocal anchorage. Option D. So this is not the bud. I think this is a bell stage. Seems to be a. I can double check from the handbook, but seems to be a bell stage. Just give me a second. Just give me 1 minute. Yeah, so we have this picture here. It's a bell stage. Okay, so this 13 years old female attempts to fix appliance fitted. She had a mild form of emergencies imperfecta, though she has no areas of missing enamel. Her enamel is thin and prone to fracture. What is the most appropriate enamel preparation and adhesive to use in this patient? No H, glass and cement. Yes, we can do it. Normal H, increase H. So I think option A is better for a melogenesis imperfecta.
Doctor, can you go back to the question, please?
It's a melogenesis imperfecta. Yeah. So this is a question.
Yeah, the answer is A, right?
Yeah.
Okay.
You asked an adult patient to start removable aligner treatment. The appliance manufacturers have asked you to use rubber-based impression material, which is the most important advantages of rubber impression compared to alginate. They are dimensionally stable. So the stability is more important than the working time. So option E. Just give me a second. Okay, in this question, a 15-year-old boy had an extraction of the upper second premolar, a cord helix, and upper lower fixed appliance treatment. At the end of treatment, what would be the most appropriate retention regime? So they have given a cord helix and upper lower appliances, uh, upper vacuum form retainer, upper Holly retainer, yes. Use upper fixed retainer, use upper vacuum form retainer, having wiring incorporated from upper left six, upper and lower Holly in conjugation with upper fixed retainer, upper. So what is the need for fixed retainer here? Like, I do not see a need here. A cord helix sample of fixed plan at the end of treatment, what would be the, like, I can go for option A here. Sorry, option D here, because I don't see the need for a fixed retainer here. So option D.
Doctor, the extraction does not necessitate the fixed retainer?
The fixed retainer is from canine to canine, and you are extracting a premolar,
Okay.
right? So if the extraction space is supposed to open, that is distal to the fixed retainer.
Yes, okay, thank you.
A mother has become very angry at the treatment you have provided for the child. You have tried to diffuse the situation and have acted reasonably, but the mother has become aggressive and is using abusive language. Before leaving the surgery, she snatches the clinical notes away from us and leave the building with notes. What is the most important? Like I share the document, they say that you have to call the local police. They will provide you a number, and then with that number, you call the dentist defense body or something like that. So this is a, so I will go with option A here. Like option D comes later. Hello. Walaikum assalam.
Option D, doctor, right?
No, it's option A. Call the police. They will give you a number. Then you have to report to the independent body, Defense Society for advice. Because they will give you a number. Otherwise, they will do nothing.
Doctor, put mark on the.
Sorry. So I didn't get it.
Doctor, just put mark on the correct answer because I didn't hear the answer. Option A?
A 19-year-old male patient with learning disability presents to your clinic with his mother. He has space teeth with increased overchat. His mother asked you to perform orthodontic treatment for him. You think that treatment would be beneficial for him. Take mother consent, take parent consent, no, take consent from the patient. The legal guardian should consent. Refuse the treatment. So I think the option D, because the patient had learning disabilities. So
Doctor, sorry, we chose the vacuum retainer because it's more aesthetic than the Harley retainer, right?
sorry.
The previous question, sorry, we chose the vacuum retainer because it's more aesthetic than the Howley.
And where is the Holly?
Option B.
Yeah.
For better aesthetics or what?
Extraction of upper second quad helix and upper loop fixed spline at the end of treatment, what would be the most approved regime? Okay, we could go for the Holly.
So the answer is B.
No, Holly retain.
But doctor,
Yeah, Holly. That's a gold
like
standard.
better
Option
retention
D
than
is
the
also
vacuum
good. Like
form?
option D is also like good. Then it's a personal preference.
Yes, I mean an
So B
exam
or D.
will choose
Yeah, even
B
D is fine.
because
Like
it's the
it's a
gold
personal
standard.
choice. If they mention like the case is open bite, I will prefer a VFR, but they haven't mentioned something like that. So the gold standard is Holly retainer for expansion cases, but that modification also works. So anyway, I
Yes,
selected D.
okay, thank you.
The mother of one your patient want to complete her daughter treatment with another orthodontist without informing you about the reason of her decision. What you will do? It's up to them. You cannot. She has a right to transfer the case, but she doesn't have the right to take her records. Yes. You should accept her decision, deliver her the patient records to her immediately. You told her that you need time to give her a copy of the case file and records. Call the dental defense counter. No. Like she has a right to transfer the case, and she also like you have to transfer the case to yourself. Like usually it's the orthodontist who transfer the case to another orthodontist. It's not the patient who take all the records with them because you keep a copy of that with you. So she has a right to transfer the case, but she doesn't have the right to take her records. Yes. Like this is correct to some extent. You should accept her decision and deliver the patient records. No. No. You told her that you need time to give her a copy of the case and the files and the records. It's not the patient who take a copy, mostly like you transfer yourself, like, or this option is also correct. D. This is not in, so we have two options here, B and D, which are like correct. She has a right to transfer the case. Yeah, so B is more option. You told her that you time. So I think D, I will go with the D. It might be subjective, but I will go with the D. Because you just provide the copy, not the original ones. A child of 11 years presented to orthodontic department with a chief complaint of prominent upper teeth on clinical examination. He has a deep bite class 2 molar relationship and OJET of 10 millimeter. His upper canine was impacted and he has a posterior cross bite, which a malocclusion should be addressed first in this case. So 11 years old patient with a chief complaint of prominent teeth on clinical examination. He has a deep bite, class 2 malocclusion, OJET of 10 millimeter, upper canine was impacted. So upper canine is the one for the most need of treatment, right? He has a deep bite, class 2, OJET of 10 millimeter, upper canine was impacted and he reposed. Not the deep bite, cross bite, ancestral relation. See, either they should be corrected together, like the ancestral relation, the cross bite, and they are trying to correct it together. Otherwise, canine should be dealt because they haven't combined. So that's why I'm selecting E. Otherwise, they should be, they can be. We do have case reports in Journal of Orthodontics. I'm selecting E here. So patient
Doctor,
attacks.
does it matter if they say that the chief complaint is the overjet?
Sorry,
Or should we address the most important malocclusion even if they said that the chief complaint is the overjet?
the chief complaint.
It's prominent upper teeth.
Yes.
Because you said one of the indications of the early treatment of twin block is the bullying and, the fear of trauma. So should we choose overjet?
See, they are dealt together early. We do have time for OJET correction. Uh, like everyone say that it's evidence of trauma, but the evidence of trauma is just 17%. And the evidence of severe trauma is hardly 2 to 3% in these patients. So mostly now they are dealing all the problems together. Like if you see the cases, they are doing a twin block for this case. They're expanding using a cord helix and they might be erupting the canine, right? Until less canine
Yes.
is in the palate.
Okay, I mean, it doesn't matter that they said the chief complaint of the patient is the prominent upper teeth.
No, it's not about
We
the chief.
choose according to
I'm not
yeah.
choosing. I said that like it should be together early because I can select
Okay.
crossbite. Then it will become subjective. I say that okay, correct the crossbite. But this patient also have this 10 millimeter OCHET because even
Yes,
if you are correcting the crossbite, you
what
would
I
be
mean is
correcting the
because
crossbite with a cross growth modification appliance.
yes, I know because only in this question they mentioned that the patient has a chief complaint of something. Other questions they don't mention. They just say he has so and so, and you have to choose according to the IOTN. So I was just asking if the chief complaint line matters in this question.
Yeah, but
But
the chief
okay, I'll
complaint,
choose according to IOTN.
yeah, like with the chief complaint, if you're doing it, crossbite would be corrected first then.
Yes, okay, thank you.
I think we did this question yesterday. It's no pulse. So we are going to give chest compressions. So option D here. A patient presented orthodontic with a chief complaint of upper missing lateral incisor and traumatic deep bite. A finding confirmed the ectopic position lateral incisor rotated FT3. So decided that ectopic like it's impacted because it's radiograph, it's visible. And here it's not visible, so 5I. Patient presented to your clinic, his OPG shows that his maxillary canine is impacted. To find the location of the canine, other radiograph must be carried out. Patient is concerned about additional radiograph. Which other radiograph would take minimum radiation dose? We decided two periapicals just for the minimum radiation dose. Otherwise, the standard one is upper occlusal.
Two
Yes.
periapical.
Sorry.
The answer is two periapical.
Yeah, because it said maximum minimum radiation dose. Yes. A 14 years old require orthodontic treatment for malaligned teeth that there was moderate crowding of 6 millimeter. So you have to calculate the power here. No, not the power. How much space would be required by the upper anterior segment for the correction malala cheaper class 1 relationship? So you have to apply the Royal London space analysis here.
Hello, doctor.
Yes.
It was me who placed this question, doctor. It's a little bit difficult, doctor. Even while applying Royal London, it was difficult.
Okay, let's apply this one then. The upper right central incisor was proclined with an OJET of 10 millimeter,
Yes, please.
while the left central incisor and the lateral incisors has an average overjet. So you have to apply like it's 10 millimeter for one single incisor. The upper lateral incisor was reclined, one of the lateral incisor, with an OJET of -2 millimeter. Okay, that's good. The left leg also need a positive torque of 10 degrees to correct the inclination. The upper right central incisor needs an inclination change of 15 degrees to correct the increased prominence. How much space would be required for the upper anterior segment for the correction of malalignment to be achieved a class 1 normal OJET of 3 millimeter? Okay, so I'll start with the incisors. Upper right central incisor was proclined with an OJET of 10. So we have to change the OJET here, 7 millimeter, right, Meena?
Yes, sir. I'm with you.
Yes. So we are supposed to change it by how much? OJ 7 millimeter change.
Okay.
7 degree 7 millimeter. For one
Yes,
single.
sir.
So what is the OJET change for 4 incisor if it's 7 millimeter?
It's 40 for 4.
4 millimeters?
14. We need a
Yeah,
14
14.
mm
Yeah,
space.
that is 14 millimeter. And because it's one single tooth, so how much? Like you divide it by 4.
0.5.
Why 0?
So 0.5 multiplied by 7. So it might be
14 divided by 4.
0.
Doctor, how did you get the 14, please? Because I have an issue with that. How did you get the 14, doctor?
Because 7 millimeter OJET need 14 millimeter space for all 4 incisors.
Okay, doctor. And how does 14 get? You mean 7 times 2, 14? This is what I'm implying.
Yes. Like if these were 4
Okay.
teeth, that was 14 millimeter. But now this is 1 teeth.
Yes,
So
sir.
it will be 3.5.
So
3.5.
how to is not this one? So 14 divided by 4. But it's not going.
3.5.
14 divided by 3.5 mm. So 3.5 mm for plus 3.5 mm, right?
So 14 divided by 4, 3.5 mm.
3.5. Like 3.5 mm is 1/4 of it, 14.
Yes,
right?
Yes, sir.
So the other lateral incisor
Okay.
is in a cross part with a OJET of -2 mm, and you have to make it 3 mm, right? So there would be
Yes,
a
sir.
space gain. So this OJET is 5 mm, -2 and 3, 5 mm, right? So for 5 mm, we need 10 millimeter space. If these are 4 incisors.
How did you get?
Yes, doctor.
No, is there any calculation of it, or doctor, or any equation for it? Because Royal London is a little bit confusing still now.
Yeah, we are doing the OJET calculation.
Yes, sir. I'm with you, sir.
Yeah, so it's 3.5 millimeter one value. Now it's -2, and we are supposed to get a 3 millimeter OJET. So from -2 to 3, it's a 5 millimeter for one single tooth, right? So this 5 millimeter multiplied by 0.5, because
So isn't it give us a space Like we are proclining it,
Yeah,
so
obviously
it
that
will
needs
give us a
space.
space.
That gives space because from minus to positive.
Yes, sir.
So
Sir, please explain how we get 5 millimeter. Please
from
explain
minus
again.
2 to 3 millimeter, how much like you are going from minus 2 to 3, how much this is?
The 1 mm proclination will give
Okay.
Yeah,
us
we are proclining by
5 millimeter.
5
2 mm
millimeter,
space.
Minus.
right?
Yes, sir.
So
Yes,
from
sir.
minus 2 to 3, it's 5 millimeter. So like the rule of
Okay.
OJT is for all the 4 incisor, 2 millimeter space for 1 millimeter OJT correction, right? So if it's 1 tooth, it's 0.5 millimeter space, right?
Okay.
For 1 millimeter OJT correction. So for 5 millimeter, it's 2.5 millimeter space, right?
Right, sir.
Or
Okay.
you can go the other way around and you can again go to the calculator. It's up to you the way you take it. Like you can make like 10 because 5 millimeter need 10 millimeter space divided by how much that is. No, it's won't be like this. Yeah, 10 divided by 4 because there are 4 incisors. 2.5 for one
Okay.
tooth, right?
Yes.
Space.
Okay.
So previously we have 3.5, right?
Correct.
So that was minus 3.5. Now we have plus 2.5. So that will become minus 1.5. Is it right?
Correct. Yes, sir.
So we have minus 1.5 now. So move to the next factor. The left lateral incisor also need a positive torque of 10 degree to correct its inclination. So how much space we need here? It's a positive torque.
So,
For 10 degree, we need 2 millimeter for the 4 incisor. For 1 incisor, 0.5.
It will be
0.5.
yes.
0.5, right? It would be minus 0.5.
Sorry, doctor. 0.5. How did you get the 0.5 for every 1 millimeter 0.5 space?
No, for 10 degree torque, for 4 incisor, that is 2 millimeter
Yes.
space required. But this is a single tooth.
Okay, sir.
So you need 0.5 millimeter space required.
Yes.
That would be minus 0.5. So previously we have 1 millimeter, I suppose.
Okay. Yes.
Because that was 3.5 and then 2.5, right? And now we have this
Yes.
minus 5. So it's again become minus 1.5. Is it right? Yes, doctors. Is it right?
Yes, minus 1.5.
Yes, it's right.
Yeah, it's minus 1.5 till now.
Yes, sir. Yes, sir.
So if I
Doctor,
move,
sorry, but how did you get? I'm sorry, doctor. You said for every 10 degrees, 2 millimeter. Okay.
Yeah.
How did you get the minus 1.5 in the end, doctor?
because we have minus 1 previously. Like I will do the writing later on. See, I do the writing right now.
Mhm.
So I have one of the incisor that is, I have to correct 7 millimeter jet on one of the incisor. So that is minus 3.5, right? From the upper right.
Yes.
Then
Okay.
I have the lateral incisor that need 5 millimeter jet change. That is plus 2.5,
Yes, sir.
right? Then I have to correct the torque that is minus 0.5. I have to give positive torque.
Yes, sir.
So if I do this equation, right, that is now minus 1.5 because minus 3.5
Okay.
minus 0.5 is minus 4. And then you minus that
Correct.
0.5 from it's minus 1.5, right? Then they say the upper right central incisor need an inclination change of 10 degree to correct its increased prominence. It means you're decreasing the inclination of that central incisor by 15 degree, right?
Yes.
So for 10 degree decrease in inclination, if these are 4 incisor, it's 2 millimeter. If it's 1 incisor, 0.5 millimeter, 0.5. And for 15 degree, that is 0.75. And that's a space gain, right? So that is plus. So what else we got now here? How much space would be required for the upper correction of the malar triangle with a jet of 3 millimeter?
So upper there was mentioned a 6 mm of crowding moderate. So we will add that.
Yes. So what is the value now? So it's minus
Sir, how
3.5.
we get this -6, please?
So
After whole calculation.
that is -1. Then with -1, minus 1.5, and the 6 minus 7.5, minus 7.75, something like that. So what is the answer?
It's a D.
Sorry?
That's D. That's minus 7.75.
See, this value is minus 3.5 and this value is 0.5. So it become minus 1. It become minus 1.5. And this become, if we minus it, it becomes minus 0.75. And
Yes,
if we
sir.
add this one, that will become 6.75.
Sir, please explain how we get this -6.
Sorry?
Please explain how we get this -6.
From here, there's a moderate crowding in the approach.
Okay. Thank you.
6 millimeter crowding in the approach. So the option B here.
Sir, D.
Sorry?
So you mentioned a B, and isn't it D?
It's B. It's 6.75. That is option B.
Okay.
It's one. So a 14-year-old patient with a moderate crowding, he has fractured discolored upper right sentinel incisor due to trauma. What would be the correct order of care for this patient? I think we decided previously it should be alignment, then bleaching, then endodontic treatment. No. He has fractured discolored upper right sentinel incisor due to trauma. What would be the correct order of care for this patient? If there is a trauma fracture, you have to deal with it first, right? So you do the endodontic treatment. Yeah, option D here. Endodontic treatment, bleaching, composite, and then alignment. You're designing a study to analyze space square rate between two bracket systems together with a significant level. What additional piece of information is required? The mean, the difference between the mean rates. I think we decided for the B. It's not fluorosis. It can be MIH. It cannot be infection, label of. It can be due to previous trauma. It's not fluorosis. I do not see the molars. It's not infection like they were given a answer like trauma.
A childhood infection that
They
like
haven't
in 10
clarified the
months,
infection here.
like in calcification there is an issue. So
So, doctor, the answer is D, infection due to trauma.
Yeah, that can be in the might be due to an infection. Usually due to trauma to the deciduous teeth. A 10-year-old boy reported to orthodontic with the chief complaint of crooked irregular teeth after thorough examination. It was recorded that the child was happy of thumb sucking vigorously for approximately 12 to 14 hours a day. It was also noted child has a V-shaped maxillary arch and procline upper incisor and retrocline lower incisor. The position of the lower molar teeth should be like we decided that displays Buckley. We have solved this question.
Yeah, option E.
Yeah. For skewed data to describe the central tendency of the data, we should, I'm not very sure right now. You can ask this question to Samir. He will join one session. 8-year-old female came to your clinic with a cross-biting upper center incisor. What is the most important component in the upper removal appliance? The most important component is the active component, right? So it's anterior cross-bite. There should be a Z spring, and that should be 0.5 millimeter. Option D here. 9-year-old boy was originally.
Sorry,
Yes.
sorry, sir. This is in last back questions. And due to thumb sucking, lower molar strip buckling.
Yes, because they say the tongue occupy a lower position. So that's why the molar usually buckly place.
Okay, sir. Okay, sir. Thank you, sir.
9-year-old boy was originally referred by an orthodontic treatment practiced by general dental practitioner for the management of unusual large incisor. Medical history revealed type 1 diabetes with no relevant medical history. Dental examination revealed early mixed dentition with class 2 malocclusion complicated by upper left one fused. I do not see is fused. Yeah, there's some fusion. Was supplementary incisor. Okay, this tooth has a meso distal width of full 14 millimeter. All other permanent teeth were present with normal morphology. And all other permanent teeth were present of normal morphology. The upper labial segment was potentially crowded and the lower arch was moderately crowded. The patient has an overjet of 3 millimeter. Complete overbite. Radiograph showed that the macrodont upper left one had two roots, like obviously it's a fusion. However, the pulp morphology was deemed unfavorable to endodontic treatment. What is the most appropriate? So it's quite big. If it's not endodontic treatment, then extraction of it. And let me see the patient. Patient is 9, but yes, like it will affect other teeth, like eruption of the other teeth. So I will go for extraction. Option E here.
Doctor, can you tell us a summary on when to extract and when to make IPR for fusion and for
There's no
germination?
summary. It depends on the question. Like they mentioned, you cannot do a root canal. It's quite a big teeth, like 14, 15 millimeter. It will impede the eruption of the other teeth.
Sir, when will we do IPR
If it's
for
quite
the
small,
drug
like 10, 12
this
millimeter,
Visadinum?
in germination cases, we can do it.
Okay.
And then do a root canal in
Okay.
germination.
Yes, when to split the tooth in two and make root canal? Other than that question that they say you can't make root canal.
Sorry?
Like when to choose that we split the tooth in two and make a root canal for both of them. If other than this
See, in fusion,
question.
you can split the tooth in two. In germination, you cannot do it. In germination, you can do IPR and you can, do a root canal treatment. In fusion, you have to do the root canals of both of them.
Okay, thank you so much.
A 3-year-old child has a parent understood his speech in the nursery. His teacher and other clinician cannot understand his words. Upon examination, found that he has severe So if this is severe, then you go for this video fluoroscopy and endoscopy. Both of them. So it's video fluoroscopy and nasoendoscopy, not nasotracheal. Yeah, both of them then. Because if severe, they do the both of them, right, at 3 years. And then they might decide for a surgery, right? So I don't know why they have given it together. So this is the main important. So if both are given, I will go with the A then. But both are done.
Sir, if the severe word were not used, then we will refer it to the speech specialist.
Yeah, no, see, if it's mild, everyone have mild there. So you refer it for the speech therapy. If it's severe, then you do this evaluation for the insufficiency and the patient might need a surgery.
Okay.
What is the most likely early removal of a temporary English device? If you remove yourself, that is option E. We discussed this. Could you indicate that why we have chosen 4H and not 4T? Because 4H comes before T. "20-year-old male has referred in orthodontic department for the evaluation of impacted canine. On clinical examination, the cusp tip of the canine was visible and tipped against lateral. He also has a missing premolar on that side as well as missing third molar. So 4H come before T. So that's why I selected. Patient with TMD and rheumatoid arthritis want to do ortho. What is the recommended X-ray? See, there should be plain X-ray, but eventually for the sinuses, you go for, sorry, for the joints, you go for MRI. So I select MRI. And you know, the radiologists see them in plain X, combined with plain X-rays. Three days after bonding, fix applying 14 lip because she has an ulcer on the lower lip mucosa, nothing is sharp. What you will do? Refer for the oral medicine, refer for PES, show the patient follow-up. If it's only on the lower mucosa, right, then I will reassure and follow up. D. The patient is partially impacted against the 6. What is the IOTN? Then 40. Mother came to the clinic with a baby. She has a class 1. She has and was having a cleft
Doctor, why 40 for the previous
because
question?
that is partially erupted, tipped against the other teeth,
So partially, yeah, partially erupted T. Okay,
partially impacted. That's erupted. So 40.
okay.
Mother came to the clinic with a baby. She had and was having a cleft lip and palate. She was asking about surgical procedure regarding a baby lip. What is the best technique, not causing scar to the palate? You can search for it like. Never heard of this question like it's written in Bristol notes for better for clip. Might be this option A, but you can search for that in Bristol notes. Try to check Bristol notes for this. So technique is length. View soft tissue, hard tissue, bilateral, based on the embryology classification, description, features, mean. SH. Yeah. Millard gives bed scar most common performed. Purely mistaken. Yeah, so they have given Millard for here. Option B here. What is the most maximum time frame between taking the impression? They used to say 7 days for silicon putty impression material. 7 days is the most common. This is a question for, INBD. So they also have this key in 7 days on boot camp. So see. What's wrong? Patient moved. ISO. Yeah.
ISO.
Yes. It's very bright.
ISO.
ISO. A 16-year-old patient attends for assessment on medical history from
Sorry, but can you explain the last one? Not a cleft lip palate, the IOTN, that 6 was impacted against the 7 is impacted against the 6.
It's far away. Like it's 8 or 10 questions back now. This one.
It was, yeah, yes, this one. Why you selected B?
What should else I should select here?
Why not I impacted?
Where it's impacted. It's partially impacted. It's erupted.
Oh, okay, take it. Yes, sir. Sorry. Thank you so much.
Thank you. So 16-year-old patient attends for assessment on medical history from that he has a type 2 diabetes. During consultation, complains of tingling sensation in the lips and begins to shaking, complaining of heart palpitation. As you're taking him to begin slurring his word, like it's hypoglycemia, we select this one. If they give you these sugar drinks or something like that, sorry, orange drinks, that's a better option. But we're selecting option C here.
Because the patient is conscious.
Conscious, we decided that we won't go for, this SDSEP. We'll use this resuscitation guideline from UK for hypoglycemia.
Mhm.
A 9-year-old female patient presented to orthodontic department with a chief complaint of prognathic maxilla. On clinical examination, she had a class 2 canine relationship and class 2 D1 incisor relationship. On cephalometric examination, SNA angle measured 87, SNB measured 76, and ANB measured 11 degrees. The treatment plan involved Hypul headgear. If the line of force of headgear passes through the center of resistance of the upper first molar, which direction the molar will move? Distal. Intrusion, bodily distal movement. Yeah, C.
Doctor, explain why intrusion.
Because it's a Hypul headgear. There would be a vertical factor.
Headgear, yeah. Okay. Yeah, yes.
Doctor, last time when I asked you, you told me it's bodily movement in this direction with some intrusion. So that's why
Yes.
my concern is that because it's through the
There
COR,
would be
doctor, center
intrusion.
of resistance.
Yeah, there would be intrusion.
Yes.
Even see if the foci part is the center of resistance, it's a bodily movement. If it's below, it's a crown
Okay.
movement. If it's above, it's a root movement. Whenever there is a high pull
Okay.
head go, there would be a vertical factor of intrusion. And when there is a cervical pull head gear, there would be a vertical factor of extrusion.
Okay, sir. So whenever there is high pull, then indirectly intrusion. Okay, sir. Thank you for that.
Doctor, if it causes medial crown tip, it's above or below the center of resistance?
Mesial crown tipping. There's no
Yes,
mesial
because there
because
was
there's
a
distal
question.
force being acted. So it would be a distal crown tipping, most likely.
Okay.
Right.
I'll send the
And
question,
the force
okay.
would be
Because
below
the
the center of
question.
resistance.
Yes, because there was a question that the answer was mesial crown tipping, so I will share it.
See, for like a distal force, how the crown can tip mesial. The root can go distal, right? The crown remain at its place, but both in cervical and hypal head goer, there are distal forces.
Yes.
So
Okay.
how can the crowns goes mesial?
I don't know. I did not understand the answer. So I'll share the question better. Thank you.
Yeah, but in that case, the least acceptable option would be the forces would be above the center of resistance.
Okay. Thank you so much.
Okay, you are
So, sir,
fitting.
option C is here.
Sorry.
Sir, option C, last question.
Yeah, option C. You're fitting lingual appliance with a 30 years old female. You are willing to use accessory as a part. You are willing to be using accessory as a part of the process. What is the most important benefit of using this accessory? Frankly, I do not see the accessory. So what is the accessory here? If you can see something, you can let me know.
He's talking about. I think he's talking about the indirect bonding technique, doctor.
Okay, so that is reduced chair side time. Retraction of the
Because you know
crown.
sometimes يعني sometimes the threat.
Yes, Meena, they are lax.
Sorry, doctor. Carry on. Attachment and reduced pressure. You know.
See, there are two options here. In fact, lax on my side.
Yes, sir.
These are the two options that are selected. But this is definite. This is not definite. Like this is debatable, but this is definite.
Okay, the reduced chair side time, definite. Okay,
Reduced
doctor.
chair side time, like everyone agrees that there is a reduced chair side time. The second thing is that sometimes it depends on the clinician, experience for ensuring precision of bracket placement.
Yes, sir. Yes, sir. Okay, got the doctor. Thanks.
Slappy. I will also see what the handbook said. Okay, say brackets are then delivered in the patient transfer tray to ensure accuracy of placement. Okay, that's good. Complaining as per request, show no significant difference in the accuracy of bracket placement between the two techniques. Right. In direct bonding does involve less chairside time, but a greater total working time for the whole process. No signals seem to exist in the bond failure rate. The accuracy of indirect bonding is certainly clinically acceptable with linear and angular transverse errors, respectively, and does not seem to perform slightly better in the upper jaw. Silicon transfer are the most accurate. Direct indirect involves similar process of cleaning. So, like, I think they mentioned for the chair side time at the dental chair that is small, and for the other factors inside does involve less chair time, but a significant working okay. Show no difference in the accuracy of bracket between the two techniques. That's evidence they have mentioned here. What is the principal mechanism of adhesion of glass enamel to the dental surface? Adhesion to the enamel's dental structure is hydrogen bond initially. The overall bond is alkanate bond. So I will agree B here. Okay, I'll stop here because I have to do the recording complete and then I have to leave the hospital. So see you in the evening, people. Right.
Doctor, I
Yeah.
have a question. Do we have 2 classes a day or only one? Because I thought
One is
only
definite.
the class
See, one is
one
definite.
is definite. Okay.
So
At
the one,
4:45,
the one at 8 p.m. I will try to do it at 8 p.m.
right?
Yeah, I try to because these are working days here. So I will inform you one day before the session. People who
So
cannot
doctor,
join.
again,
Yeah.
we have session at morning and at evening.
No, morning session is not compulsory because I'm trying to end the previous MCQs. So it's not a session. If you want to join, it's up to you. I will provide you the recording.
Okay, I see.
Thank
So
you so
the
much.
definite session at
18. I will try
4:45.
to try 8 in the evening.
Sir,
8.
8
sir, why
EST
did you
time.
select hydrogen?
8. Okay. Thank you.
Excuse me, sir.
Yes.
Sir, you selected hydrogen bonds for the GIC bonding.
Yeah, initially it's a hydrogen bond for the adhesion. The overall bond is polyalkylate bond or a strong ionic
So,
bond.
but the E option was the polyalkylate bonds.
That's overall
So,
bond. It's an initial
when
adhesion is
we,
by the hydrogen bond.
they will mention about the initial
Yeah,
adhesion
if they
in the
mention it.
question.
Yes.
Okay. Thank you, sir.
Okay, see you.